So when Chris and I were putting this course together, we thought hard about inviting a person from outside the local world to sort of kick off the first Mount Sinai Live Endoscopy course. We thought about innovators in endoscopy, and Rob Hawes came to mind immediately. And Rob has truly been an innovator in endoscopy for many, many years. Very early on in the endoscopic ultrasound world, he was sort of like out there talking about things that nobody else was talking about. Has had a long career in Indiana, then at the Medical University of South Carolina, where he was for almost 20 years, and then left a number of years ago to move to Orlando, Florida, to start really an endoscopy practice at a minimally invasive center that he's really established in Orlando, Florida. We could think of nobody better, actually, to help kick off this inaugural course. So we asked Rob to fly in from Florida and grace us with two lectures today. The first one that he is going to talk about the first thing that he's going to talk to us about is the present and future of endoscopic ultrasound. So all the way from Florida, Rob Hawes. Thank you.
Thank you, David, for the kind introduction. It's really an honor and a pleasure for me to be here. This program is storied in endoscopy, and one of my real heroes is sitting on the front row. Jerry Way has been a friend and a mentor and a guide and to me throughout my career. So I'm very happy to be with him. I'm excited that David has come on board. He's also been a very good friend for a very long time, and I think with Satish and with Chris as the young bucks, this program is really going to go forward. So I'm really pleased to be here. So I've been asked to talk about the present and future of endoscopic ultrasound, which is always a difficult subject because you don't know what and how much to include, but I'll try to do my best to try to summarize this. This is not a sexy topic, but going forward, for the present and going forward, EUS will be involved in the evaluation of submucosal masses. And I show you a picture here on the left. This may not be exciting to all of you because it's fairly routine now. But in 1987, when I first began doing endoscopic ultrasound, this was an amazing picture. For an endoscopist to go from just seeing the lining of the gut to actually seeing the entire layers of the gut with histologic correlates was really exciting. And we've parlayed that into a very effective evaluation of submucosal masses. So the lumps and bumps that you see endoscopically can be interrogated by EUS, and that will be and continue to be a future for EUS because there's no other imaging modality that can resolve the gut wall layers as EUS does. The next one that we have been doing and will be doing in the future is EUS-guided tissue acquisition. When I was at Indiana University in 1992, we were the first center to do FNA under EUS guidance. So that was way back in 1992. This has become the driving force for EUS over the last decade or so, and it will continue to be a major driving force for EUS. We have been working in the past, since 1992, on cytology. So the idea of putting a needle into a lesion, aspirating and getting some cells, looking at preparing those, and then looking at them under the microscope. And we've been basically determining whether or not there is malignancy there or not. And so it was primarily a diagnostic situation. In the future, it is going to be more about characterization. So it's going to be more than just saying, I've got a malignancy here. It's going to be about characterizing that malignancy to better allow the patient to be treated either by chemotherapy or by surgery. At least at this point in time, what we call ROSE, rapid on-site evaluation, is still the standard of care. A number of studies have shown this, but the diagnostic yield, the number of indeterminate reads, and the number of unsatisfactory samples are all optimized if you have in-room cytopathology. So it's something that you should strive for. It's not something that everybody can attain. In Europe and in Asia, it's a rarity to get a cytopathologist in the room. It's more common in the United States, but it is valuable in getting an accurate diagnosis and minimizing the numbers of redos. Your pathology services determine how you get tissue acquisition. So if you have in-room cytopathologist, then you do rows. If you have in-hospital cytopathology, then you get what's called a cell block. So you take a sample, you put that in a preservative that is spun down and then looked at by the cytopathologist at a later date. Or if you have no cytopathologist, then you have to get core tissue. You have to get a core piece of tissue as you would with liver biopsy, etc. No cytopathologist in the hospital is a rarity in the United States. It is still present in other parts of the world. Looking at definitions of samples, cytology is basically, it's an art, but it's the idea of staining and interpretation of individual or small groups of cells. A cell block is a specimen, again, obtained by US-guided FNA, but the sample is placed in a jar. It's then centrifuged, and you get at the bottom a pellet, if you will, and that pellet is then handled like you would any other specimen. It's fixed in formalin, then fixed in paraffin, and then divided and stained. A core tissue is one that maintains the intracellular architecture. And the intracellular architecture for a pathologist is critical for them to make the diagnosis. So this is the algorithm. If you're starting an EUS program in your hospital, you need to know what your pathology services are. If you've got a cytopathologist in the room, then you'll do smears and probably a cell block. If you have a cytopathologist in the hospital, you'll get a cell block and perhaps a core. If you have no cytopathology, then you have to get a core. So the current strategy for an endosonographer to get tissue is dependent upon what your pathology services are like. So this is the future of EUS-guided tissue acquisition. In the past, it was about determining malignancy or no malignancy. In the future, it's going to be about characterizing the actual tumor. So we've gone from diagnosis, but now we know from breast cancer, from lung cancer, from many cancers, that the treatment is actually dependent upon a further interrogation of the tissue. And also the prognosis now. We can get prognosis based upon molecular genetic staining of these tumors. So there's boutique chemotherapy, radiotherapy that is delivered based upon the molecular evaluation of a tumor and the clinical outcome and the prognosis that you can transfer to the patient is also dependent upon tissue and increasingly so. This kind of analysis, the molecular analysis that can be done and needs to be done in the future actually requires greater volume of cells. So instead of just getting a cluster of cells and making a diagnosis, we as endosonographers need to get better amounts or greater amounts of tissue. We can do that with existing needles, with existing bevel needles that we've had, but a 19-gauge needle will get greater tissue than a 22-gauge needle, which will get greater tissue than a 25-gauge needle. But there are new needles on the block now, and these are beginning to be studied in a formal way. We've had a needle from Cook that's available. This is one from Medtronic. This is from Olympus, and this is from Boston Scientific. You can see here that the bevel on these needles has changed, and at least preliminary data, and we've recently published some data on the Acquire needle, seems to suggest that these new bevel needles are getting a greater volume of tissue. Not necessarily a core, but a greater volume of tissue. And that greater volume of tissue is likely going to be needed as we go to the future. So the future needs for EUS needles, we need to, if we can do ancillary studies, these molecular studies on FNA type specimens, but there needs to be a sufficient volume of tissue. FNB needles, these so-called new generation FNB needles, do not necessarily need to provide a core unless you have no cytopathologist, but they do need to provide a greater volume of tissue in order to do the molecular staining. A third future, if you will, a present and future for EUS, and one that I think is very, very exciting, are interventions. This is a summary slide of all the EUS interventions. It's a little bit of a busy slide, but I show it mainly to demonstrate to you that it's actually been quite a while that we've identified various interventions by EUS guidance. And as typical in medicine, oftentimes it's a long time for techniques or technologies to really come into clinical practice. These have been bubbling along for a while, but I think now we are on the cusp of seeing some of these really impact clinical care on a regular basis. But all of them were described before 2007. If I peel some of these off, EUS-guided drainage of pancreatic fluid collections has actually become the standard of care. So it was the first technique described in 1992, and now it is the standard of care in the management of pancreatic fluid collections. If you look at celiac plexus neurolysis, it's effective. There have been not enough studies to really demonstrate its role opposite radiologic guided or fluoroscopic guided CPN, but it is effective. Cyst ablation has many issues to be resolved, but I think it holds great promise. Gallbladder drainage and biliary drainage I'll talk about in a minute. So the future for PCF drainage, I think for pseudocysts, we simply need to refine the technique. We're battling now whether or not these new lumen-opposing stents are better than plastic stents for pseudocysts. Probably they're not going to be, but we need to do studies on that. But the big issue now is walled-off necrosis. And we really need to study the algorithms of care, the place for these lumen-opposing stents. We need to improve necrosectomy techniques, and we need tools that are safer to use, etc. With celiac plexus interventions, I think we need to improve the results of neurolysis, and whether that is a different way to inject or a different substance to inject, or whether it's radiofrequency ablation of ganglia, I don't know. But we need to improve the technique as we go forward. For pancreatic cyst ablation, this was described first by Bill Brugge at the Mass General, and there have been some studies now injecting either alcohol or alcohol and paclitaxel with some variable results so far. But going forward, I think the future is bright. At our institution in Florida, we have a fair number of elderly patients in Florida, but we saw almost 1,000 cysts last year for EUS. So we're seeing a lot of cysts, and I think this does hold some promise. We need to improve the characterization of the cysts as we go forward, and whether that's fluid analysis with proteomics or some other mechanism we need to pursue, whether it's confocal microscopy to look at the surface of the cyst, whether it's biopsying the cyst. We have forceps now that will go through a 19-gauge needle, whether it's OCT or whatever. We need to study these modalities, but we definitely need to do a better job of characterizing the cyst. We then need to optimize the ablation technique, and whether that's chemotherapy, whether it's RFA, whether it's microwave, I don't know, but we need to optimize our ability to ablate the lining of the cyst. And then we need to improve ability to assess complete ablation of that cyst, and we need to optimize the follow-up. So there's a lot of work to be done for Chris and Satish and the rest of the group here, but I think that cysts are promising. EUS guided gallbladder drainage is an interesting a thing for me. We've been doing it now for a little while, and this is a summary of the literature, 8 studies, 12 case reports, only 155 patients, but the technical success is actually quite high to be able to access the gallbladder and then drain it either through the antrum or through the duodenum. The overall clinical success is high, and the adverse event rate is reasonably low. The technique is not standardized. We don't have the right tools in all cases. Bile leak is still a problem. Whether lumen-opposing stents are the answer or not, we don't know. But this is, in some respects, I think, a promising thing. There have been some studies now. You can track technology and techniques. And early on, you can sort of dismiss the reports in many respects because they will be overly optimistic. But when you start seeing randomized trials against standard therapy, then you can know that a technology or a technique is sort of coming to fruition. And here is a randomized trial in acute cholecystitis. It was designed to be a non-inferiority trial, and you can see here that they actually showed that they were equivalent to percutaneous techniques. They also showed that the pain scores were much less for the EUS guided approach. There are some problems, however, with this, and it's one of those situations in which technically it can be done, but is it the right thing to do for the patient? The initial studies have shown it to be feasible and safe, but the key is really identifying patients that are never going to be candidates for cholecystectomy. If you talk to a laparoscopic surgeon, that's about 0.000001% of the population. A good laparoscopic surgeon feels that they can do a cholecystectomy on virtually any patient. The problem is that if you drain them through the gallbladder, through the duodenum, then it welds the gallbladder to the duodenal wall. And that's very, very problematic for the surgeon and is sort of a no-go. So will it replace and can it replace PTC? I don't really know. EUS guided biliary drainage, I think this is a promising area. There have been a number of reports. There have been 3 randomized trials and many, many reviews. But the literature is still, in my view, not robust enough. It seems to be relatively successful in terms of achieving drainage in about 90% of patients. It seems to be reasonably safe in terms of its complication rate. And what is the future? Well, again, it's proven to be safe. The key now is really how it fits in with ERCP. Is it going to be more effective? Does it require less training to do? Will it become the standard in altered anatomy? I think these are the questions that have to be answered by the next generation of endoscopists. I show this slide only to say for those of endosonography people who think that it will replace ERCP, this is a study that we did of 1,000 consecutive ERCPs. 524 of them had a native papilla, and either using standard techniques or advanced techniques, we were able to cannulate in about 98.3% of cases. So if you're requiring a failed ERCP to be a requirement for EUS guided drainage, then I think with good technique, it's not going to have much of a role. These were patients, the last slide were patients that had a previously failed ERCP, and we were successful in cannulating them in all of them. So we don't apply EUS guided biliary drainage very often. In terms of therapeutic techniques in the future, pelvic abscess drainage, FNI, brachytherapy, fiducial placements, and EUS guided vascular therapy are all still being studied, and none of them are really standards of care. For pancreatic gastrostomy and rendezvous, for EUS guided gastrojejunostomy and EUS guided access and altered anatomy, I think these are exciting areas, but too young to speculate on. This is a slide from Takao Itoi in Tokyo and the EUS-guided gastrojejunostomy technique that he's employed. I think it's an interesting technique. The question is, how will it compare to duodenal stenting, endoscopic duodenal stenting? My final slide is about cancer staging, and this is what I grew up on. This was where I earned my living early on in EUS. But the fact of the matter is that for esophageal, gastric, pancreatic, and rectal, our role is actually diminishing, and it has to do with the advent of, not the advent, but the improvement in CT and MRI and PET CT, and it also has to do with improvements in neoadjuvant chemoradiotherapy and the way that surgeons and oncologists are treating cancer. But we are seeing a diminish in the role of in cancer staging. And the final area that will persist is in the area of the evaluation of pancreatic disease. And this is sort of a trend that you've seen. It used to be that there were endosonographers and there were ERCPists, but now the two have fully amalgamated. And that's because EUS really does play a critical role in the evaluation of pancreatic disease. It is useful in the evaluation for chronic pancreatitis. I've talked about cyst evaluation. It's not so useful in staging pancreatic cancer, but perhaps in the future with contrast agents and improved transducers, maybe we will regain our role. It's critical in the diagnosis with tissue acquisition, and maybe in the future we will have treatment, and it is the standard of care for pancreatic fluid collections. In terms of chronic pancreatitis, I think the main power in EUS is actually its a negative predictive value. So if you have a normal EUS, you do not have chronic pancreatitis. And I think that's a powerful tool in evaluating people with idiopathic epigastric pain. So I think the future is bright. The present is pretty good. And for those young people in the audience, I think that EUS is really a discipline that if you have interest in endoscopy is one that you should pursue. So David, again, I thank you for the chance to be here. I'm really honored. Thank you very much.